Hi, my name is Abby LeMerise, and I'm a student nurse at the University of Michigan. Today I will be presenting a patient. Patient is an 18-year-old Caucasian female who is single and currently and usually a student. Her usual source of medical care is a primary care physician through the Cleveland Clinic in Cleveland, Ohio. The patient's vital signs were as follows: a blood pressure of 115/75, a heart rate of 60, a respiratory rate of 16, and a temperature of 98.6 taken orally, as well as an oxygen saturation rate of 99% on room air. Her height is 5'1" and her weight is 145. Patient is seeking care for drainage, redness, and swelling around the umbilicus relating to a surgical incision, as evidenced by a recent colectomy and ileorectal anastomosis. Patient reports an onset of pain in the umbilicus starting 4 days ago related to surgical incision. Patient described the pain as constant, sharp, and lasting over the last 4 days. Pain is located in the inferior umbilicus. Aggravating factors include contact with the area, and alleviation is brought on by bringing a cool air stream directed at the area. The patient has treated the pain by taking extra-strength Tylenol every 6 hours and reducing activity to bedbound with slight mobility. Patient is unable to do any normal daily activities independently. Associated symptoms include pus in the incision, swelling, and redness. Patient appears distressed and anxious about the problem and believes to have an infection. Now I'm going to speak about the patient's general health history. The patient's history of childhood illness includes frequent ear infections and occasional cold and flu symptoms. At the age of 10, the patient was diagnosed with familial adenoma polyposis, which is an inherited condition in which numerous adenoma polyps form throughout the digestive tract. These polyps start off benign, but malignant transformation into colon cancer occurs if untreated. Psychologically, the patient reports no illnesses. The patient is up to date on all immunizations, starting with the recent flu shot. Last tetanus shot was 2013. Patient has no known drug or food allergies or reactions, but has a high tolerance to anesthesia, as evidenced by extreme nauseousness. In regards to hospitalizations and surgeries, at the age of 2, the patient was hospitalized due to a fractured left femur from incurring a fall. 4 weeks ago, the patient was hospitalized and had surgery for a complete colectomy and ileorectal anastomosis. The patient was post-op in the hospital for 8 days and was discharged for further recovery. The patient is currently taking 150 milligrams of Selindac daily, which is to lessen and prevent the polyp sites throughout the GI tract. She has no history of drug or alcohol use and exercises 2 to 3 times a week through recreational sports and leisurely jogging. She sleeps an average of 8 hours a night. Patient ingests around a 2,000 calorie diet through 3 meals and 1 snack and follows a vegetarian diet consisting of adequate protein intake. Patient consumes an average of 1 cup of coffee daily and has no history of smoking. She wears seatbelts, reports no texting and driving, wears helmets and sunscreen. The patient's parents have been married for 28 years, and she is the youngest of 3 children. She has 1 brother who is 20 and 1 sister who is 22. There are no reported issues within family or friend relationships. Daily stress level is reported around 6 out of 10, and stressors include attending school at the University of Michigan, balancing her work and daily activities. Patient lives in a school-funded dormitory and is very seldom exposed to secondhand smoke. She is a practicing Christian and is highly involved in her church community. She has a high school diploma and is currently enrolled in a bachelor's program. She receives a yearly physical through a primary care provider and also sees the dentist twice a year. The patient's disease is hereditary, and her mother, sister, maternal aunt, and maternal grandfather all present with familial adenoma polyposis. Sister received a complete colectomy and ileorectal anastomosis in the year 2011. Mother had a complete colectomy and ileostomy with an internal J pouch in 2001. Maternal aunt had a complete colectomy and ileostomy along with the removal of the duodenum and an internal J pouch in 2003. The maternal grandfather had a complete colectomy, ileostomy, along with the surgical removal of the duodenum and gallbladder and an internal J pouch in 1986. Brother, father, and paternal extended family show no signs of obvious health concerns. Maternal great-grandfather died of colon cancer, but all other family members have died of natural causes or old age. The paternal aunt has history of melanoma. While reviewing the patient's integumentary system, the patient's skin shows no abnormal dryness or rashes. The patient has been experiencing pruritus around the inferior umbilicus. The patient's aunt has a history of melanoma, so patient is predisposed and due to ethnicity burns easily. Patient has not spent long periods of time in the sun and regularly wears sunscreen. Patient has seen no recent changes in hair and nails. Patient's skin around the surgical incision within the umbilicus has become inflamed, red, itching, painful, and drainage of pus is present. While reviewing the gastrointestinal system and reviewing the patient's nutrition, patient reported no frequent heartburn. Since her abdominal surgery 4 weeks ago, patient has experienced infrequent digestion paired with regular diarrhea and nausea. Patient has also experienced changes in bowel habits in the past 4 weeks and experiences pain with bowel movements in her abdominal area. There is often blood in the stools along with infrequent random bowel movements. Patient's usual bowel pattern before surgery was 2 normal bowel movements daily accompanied with no pain. Recently, patient has reported a weakened appetite and cannot tolerate normal amounts of food or foods that are difficult to digest. Patient shows no signs of jaundice. She has a history of colon polyps related to her familial adenoma polyposis. During the abdominal exam, the patient's skin color was consistent with the rest of the body with the exception of the umbilicus. The contour of the patient's abdomen is flat and the umbilicus is inverted with abnormal redness, swelling, and drainage. There were no visible surface motions upon inspection. There's a horizontal scar present that is 2 inches long, found in the hypogastric region. There's a half-inch scar in the inferior umbilicus and bilateral horizontal scars in the right and left lumbar regions that are 1/4 inch long each. All scars can be attributed to a previous laparoscopic colectomy. Hypoactive bowel sounds were auscultated in all 4 quadrants. There was no bruit present on auscultation of vascular sounds. Upon light palpation, patient experienced extreme pain, therefore deep palpation was not performed. Absent palpable pulsations of the aorta were also not heard. Patient range of motion was graded at a +1 for iliopsoas and obturator test. Because of grimace and guarding, rebound tenderness was not performed and Bloomberg's test was not tested. During the integumentary assessment, the skin was found to be clean, not including around the umbilicus, with a normal amount of perspiration. No excessive body odor was present. Color, tone, and pigmentation were all presented normal except for around the umbilicus. Moisture, texture, and thickness of the skin were normal. No lesions were found, and 4 abdominal scars were found as previously stated. No edema was palpated. Mobility and turgor of the skin was normal, and temperature was equal bilaterally. During the inspection and palpation of the nails hygiene, color, shape, and contour and thickness were all normal. All nails were attached, and capillary refill was less than 2 seconds. Inspection of the scalp found no flaking or lesions, and scalp and body hair were normal in the amount, distribution, color, and texture. The pertinent systems related to this patient are cardiac and respiratory assessments. According to research done by the Department of Anesthetics and Thoracic Surgery in Bradford, England, the incidence of pulmonary complications is higher after upper abdominal or chest surgery than operations on other parts of the body. These wounds produce a severe and prolonged alteration in pulmonary mechanics. Impaired ventilation and ineffective expirtation result in the postoperative failure of expansion or progression of collapse of lung segments, thereby encouraging infection. Due to the patient's recent abdominal surgery, the respiratory system should continue to be assessed to make sure no complications are arising in the lungs. Furthermore, according to research done by Mandy Perrin, a fellow of the Royal College of Anesthesia, speaks in the Oxford Journal regarding how an increase in intra-abdominal pressure, which is a result of an insufflation of gas into the peritoneal cavity during laparoscopic surgery, can lead to cardiac complications. An increase in intra-abdominal pressure results in the compression of the inferior vena cava, reduction in venous return, and subsequent decrease in cardiac output. For these reasons, the nurse would want to assess the cardiovascular system, making sure that the post-operative patient is not experiencing any problems regarding that system. This concludes my presentation of my patient information. Thank you.